All right, hi everyone. It's really nice to see all of you here for our session on drug checking. This is going to be a really exciting panel. Maybe I'm biased as like a drug checking technician whose my entire life revolves around drug checking. I think this is really cool, but so this session is called Drug Checking, New Settings, New Drugs, Understanding Consumer Decision Making. So we're going to hear from a lot of experts from across the world. It's really exciting to have them here. My name is Yarelix Estrada. I'm a drug user. I'm a drug checking technician. I'm an activist, drug checking manager and trainer. I'm also a psychedelic organizer. I do a lot of stuff around drugs, as I'm sure a lot of you also do as well. So when it comes to drug checking, the work is extremely interesting and vast. The chemistry can be complex, and the community and the trust that's cultivated is really critical to the work that we do. Today, we're diving into several aspects of global drug checking, including from how our communities are utilizing our drug checking services, to different research projects, to mysterious new substances that are found in our supplies, as well as the trends that we see across different regions. So I feel very privileged and excited to be with so many experts from across the globe. We have 6 different people that are going to be presenting about their work, about their projects, future of drug checking, things that we're all doing in our respective regions. So I'm going to get us started with Sam Tobias. And Samuel Tobias is a doctoral candidate at the University of British Columbia School of Population and Public Health and a graduate researcher with the British Columbia Center on Substance Use.
Hi, everybody. Thanks for sticking around. Let me start this out. Can you hear me okay? No? Better? Okay. Thanks, Yarelix, for the introduction, and thank you, everybody, for sticking around today. Thank you. So I want to start by acknowledging that I'm visiting from the unceded traditional territory of the Coast Salish people. That's including the ancestral homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. But the research I'm presenting on today was conducted across the unceded territories of over 200 First Nations. So I want to begin with some background about the unregulated drug poisoning crisis in Canada. Since 2016, there have been over 50,000 Canadians who have died of opioid toxicity. And in British Columbia, the westernmost province on the Pacific coast of Canada, has the highest drug-related mortality rate, and which is the leading unnatural cause of death in the province. A staggering 16,000 people have lost their lives to toxic drugs in the province since 2016, when the public health emergency was declared. In recent years, 85% of people who have been found to have died from drug toxicity through coronial investigations had fentanyl detected in their systems. But we're also contending with an unregulated opioid drug supply, heavily adulterated with benzodiazepines, and in recent months, almost 50% of people who've died from toxic drugs have had benzodiazepines detected in their system as well. In response to the growing drug-related mortality, and along with other harm reduction measures, such as ramping up of take-home naloxone services, and the expansion of supervised consumption services, BC turned to drug checking as a way to combat the crisis. The pilot in the province launched in 2017, but has quickly grown to be one of the province's key responses to the unregulated drug toxicity crisis. BC's drug checking landscape is made up of nonprofit service organizations and health authorities that deliver or support the delivery of drug checking services in community sites. With few exceptions, drug checking services are generally offered with Fourier transform infrared spectroscopy, or FTIR, with complementary fentanyl, benzodiazepine, and xylazine immunoassay strips. Some sites are independently funded, such as Get Your Drugs Tested, but there are also sites that offer different types of technologies, such as Substance in the University of Victoria, who pioneered paper spray mass spectrometry and the distributed drug checking model. Substance also generously provides secondary analysis for other sites across the province, and BC is unique in Canada in that we have strong provincial support for drug checking compared to the other provinces. The BC Center on Substance Use, who I work for, operates as a centralized hub or a backbone organization that provides data stewardship and management of the provincial drug checking results database. It also offers technician training and a community of practice, as well as develops the standards and guidelines for the province. We're partnered with Health Canada's drug analysis service, our federal drug lab, in which they receive a limited number of confirmatory testing results, or provide confirmatory testing results using gold standard laboratory-based technologies. And to date, among our projects affiliated sites, there have been over 150,000 drug checks using FTIR and test strips in the province. So separately from this, the British Columbia Centre on Substance Use has been conducting an evaluative survey of drug checking. Our study team interviews people who use drug checking services about their experience in accessing the service, as well as some other relevant information. The survey is conducted either in person or over the phone, following a recruitment from drug checking sites, and is administered by research assistants or interviewers, some of whom are people with lived or living experience of substance use and drug checking service use. Promotional materials are distributed at sites where drug checking takes place through both technician referrals and the material distribution. We recruit from 22 sites across the province, and participants receive $25 for participating. The study I'm presenting today was based on surveys conducted between March of 2020 and July 2024. We wanted to investigate the behaviors that individuals enact after receiving unexpected drug checking results. We felt that by identifying the factors that motivate these risk reduction behaviors, this research could enhance our understanding of how drug checking services may effectively improve safety and mitigate risk among people who use drugs. Much of our evidence informing drug checking service delivery and funding has come from qualitative research and on willingness among potential service users, or has been based on intentions following the receipt of results, or intentions of a hypothetical situation. So research has been generally conducted on intended rather than enacted behaviors, and is largely limited to recreational settings, or have been based on the results of a binary fentanyl test strip. So we asked participants what drug did they last check, and what were the results of that drug check. Most participants performed the survey shortly after getting their drugs checked, and many still had the results slip that was given to them by the technician at the time. From that information, we determined if participants' drugs contained unexpected active ingredients, and we defined active as something with psychoactive properties, and unexpected is pretty clear. That's something that was not expected to be there. And although it might fit both criteria, we excluded caffeine from this list because it's the most common diluent for opioids in the province. We also asked participants following their drug check, what did they do with their drugs? Practices we defined as risk reducing included taking a tester shot, taking less, diluting their drug, seeking supervision, splitting into smaller doses, disposing it, using over a longer period of time, or using it at a supervised consumption site, giving it away, selling the drug, or self-reported others that met our subjective threshold of risk reduction, such as getting a nurse to help me or doing a smoke test. As a sensitivity analysis, we recategorized responses related to giving it away or selling it into the no category, because while these may reduce the risk for the person who got the drug check, it may have increased the risk of a negative health harm for somebody else in the community. We then conducted a multivariable logistic regression and controlled for variables that we believe to be associated with this relationship. Our study sample included 447 individuals from across the province of British Columbia. The median age was 43. 33% of the participants identified as a woman and 2% as a gender minority. 27% identified as Indigenous, Black, or a person of color. 30% of our study population was unhoused at the time of the survey. And 81% reported greater than weekly stimulant use, and 79% reported greater than weekly opioid use. And to measure enacted behavior change, we removed participants who reported that they had not yet used the drug that they had checked at the time of the interview, other than reporting something like they weren't going to use it. Now to the results. 39% of participants reported an unexpected active drug in their sample, and of that, 20% were in the absence of the expected drug. The most common unexpected active drug was a benzodiazepine in a sample expected to be an opioid, and we found fentanyl in expected methamphetamine and benzodiazepines in expected crack cocaine. 24% of people with unexpected drugs reported that they enacted a risk-reducing behavior, compared to 14% among people who did not have an unexpected drug. And from the multivariable analysis, you can see that people with an unexpected active drug were 2.24 times more likely to engage in a risk reduction practice, which was a significant result. From the sensitivity analysis, where we recoded sold and gave it away as non-risk reducing, the results were similar, with 2.59 times the odds of engaging in a risk reduction behavior. Our study does have some limitations I want to mention. First, the survey encompassed a non-random recruitment, which could limit generalizability. And although most participants conducted the survey shortly after the drug check, because our inclusion criteria was 6 months since the drug check took place, there exists the possibility of recall bias or people not properly remembering their drug checking results or their actions that they took. We also can't ignore the possibility of social desirability bias, skewing people's reporting of their risk-reducing behavior change. And finally, because this was a cross-sectional survey, we're limited in our ability to make causal inferences about this relationship. But however, we introduced temporality in the way the questions were structured to ensure the action was performed after the drug check took place. So to wrap up, we found that people who reported the presence of an unexpected active drug in their drugs were 2.24 times more likely to engage in a risk reduction behavior after getting their drugs checked. This result reinforces the value of drug checking technologies capable of detecting a wide spectrum of components such as FTR spectroscopy or mass spectrometry. It also suggests opportunity for the development of more tailored harm reduction counseling as we continue to learn what motivates these risk reduction behaviors. However, given the limitations of the voluntary participation and self-reported data, further research is needed to understand how drug checking influences decision-making across diverse groups and contexts. Future studies should also consider how different types of unexpected results are interpreted and acted upon by people who use drugs, their distributors, and service providers. The study would not have been possible without the people who took the time to complete our survey, so I thank them for their time and involvement. I also want to thank the current and former staff and researchers at the BC Center on Substance Use and all our community partners who helped develop and roll out the survey. Thanks for your time, and I look forward to chatting in the future.
Not this tippy toe. Thanks so much, Sam. That presentation was really interesting. I know for a lot of folks who are not in doing drug checking, we get asked a lot, like, how do we get money? And unfortunately, sometimes we need to get that sort of data to be like, it helps people be safer and healthier. So things like this that are really important for our work. Next, we are going to have Perrine Roux. Perrine Roux is a public health researcher with over 20 years of experience in the fields of HIV, hepatitis C, and harm reduction. She is a PI of several mixed methods, multidisciplinary projects related to access to care and prevention for people who use drugs, and has over 80 publications in this field. She's also the coordinator of the Perrine Network, a harm reduction research network gathering academic researchers and organizations of people who use drugs.
Thank you, Yarelix, for the presentation. So, are you ready for the best accent ever? So I'm very happy to be here with you. Thank you for coming in this late session. I'm going to present you the first results of our cohort, Checknow, which focus on factors associated with the use of drug checking in France. And I would like to thank all my colleagues that participated on this analysis. So, first, I would like to present you the national French situation regarding drug checking services. As you can see on the map, which is France, you can see well-distributed access to drug checking services with a main national network called Analyst on Prod, with also other initiatives in the country. And this is also based on different drug checking techniques. We have in France two modalities of drug checking service. The main one is the classic one is face-to-face drug checking, accessible through harm reduction program or through outreach program. And there is also an innovative way of analyzing the drug by a remote drug checking service. So I'm going to present you in detail this service, which is not very common. This remote drug checking is proposed by a collaboration between Psychoactive, which is Psychoactive, which is a people who use drug organization, and Analyst on Prod, the national network. So it's a system that enables people who use drugs to have their drug analyzed free of charge and anonymously. So you have to email, to request by email to the Psychoactive team, and the team will check the feasibility of the drug analysis, will send the instruction, online form, laboratory address, and a tutorial, packaging tutorial to send the drug, the sample. Then the person has to fill in the form. She obtains a unique ID number, and the drug sample has been to be packed and sent to the laboratory. The lab will analyze the drug, and then the results are entered into a database. And finally, there is a public publication of the result on the Psychoactive website, but also, of course, an access, confidential access to the result by the person using the ID number. And there is also a possible discussion on the result with the Psychoactive team. So the main objective of our Checknow cohort is to assess the effectiveness of drug checking among people who use drugs in terms of risk reduction behaviors, as the same outcomes than Tobias presented. Also health complication decrease, empowerment, knowledge sharing among people who use drugs. But I'm not going to present you this today because it's an ongoing cohort and we do not have some result on effectiveness so far. So I'm presenting now as a secondary objective based on the baseline data, which is to understand the impact of people with drug characteristics on drug checking uptake. And we will distinguish the different modalities of a drug checking service, face-to-face or remote. The method that we used, first I have to explain that it is a community-based participatory research which has been developed from the very beginning with Psychoactive, which is a people who use drug organization. And also we decided to ensure the community-based profile of this research. We developed a community-based committee that follows the research. And this committee is composed with all these organizations that you see on the right. The study design, as I told you, is an E-Cohort among people who use drugs with questionnaires at baseline, 6 months and 12 months. This analysis is based on the baseline data. And because of this community-based profile of this research, we adapted the promotion campaign to attract people with drugs in our research and to make confidence for them to be part of this project. So this is the visual campaign that we proposed with the sentence, I'm turning our experiences into knowledge. I choose to participate in the Checknow study, and it worked quite well. In terms of statistical analysis, we used a nested logistic regression on baseline data, more than 1,000 data, to understand. So the two objectives: first, to understand who use drug checking. So we compared people who use drug checking and those who did not. And we did another nested analysis, selecting only people who has used drug checking to compare those who used remote drug checking and those who used face-to-face drug checking. In terms of description of our study sample, we reached 1,363 participants. We selected only those who were aware of drug checking existence, so a total of 987 people. And among this population, half of them have used drug checking, and 14% remote drug checking, and 33% face-to-face drug checking. In terms of characteristic of our study sample, we have a quite young sample with a median age of 27 years old. In terms of gender, we have a majority of cis men, 58%, 32% women, and gender minority, 10%. In terms of housing, we have people reported having stable housing for 66%, and 18% reported living in a very rural area. 55% were employed, 17% reported ever injected a drug, and 45% used cocaine in the last months, and 20% speed in the last months. The first result regarding the comparison between people who use drug checking and people who did not show that older people and employed people were more likely to use drug checking. In terms of drug use, those who used speed or research chemicals or those who inject drugs were more likely to use drug checking. And finally, an interesting association is the association between self-efficacy, which is a proxy of empowerment, and drug checking, the use of drug checking service. For the second analysis, comparing remote drug checking use and face-to-face use, we found that people who use postal or remote drug checking were older. Those who were female or from gender minorities were less likely to use drug checking, like those who had a stable housing situation and cocaine use. And the interesting result was that people who live in a rural area, so I should have inverted the result, but the people who lived in rural area were more likely to use remote drug checking. So as a conclusion, we have very encouraging results for regarding the drug checking deployment in France, because people knows it, 72%. People uses it, half of the sample. Regarding drug checking in general, there is a more important uptake among specific subpopulation, older and high socioeconomic level status. So it is important to adapt drug checking services to underrepresented population. And finally, the important result should help us to advocate for maintaining this service, remote drug checking service. The results show that remote drug checking is a complementary approach to face-to-face drug checking. And we also have to adapt it to a subpopulation which are not well represented. And I would like to thank you for your attention.
Hello? Okay, cool. Thank you so much, Perrine. That was a really awesome presentation and also a huge part of drug checking that is really important to be able to make services accessible to our communities, are figuring out alternative models to make drug checking accessible. So mail-based or remote drug checking is really important. So our next presenter is Charlie Summers. And Charlie is a medical anthropologist and researcher at the Opioid Policy Research Collaborative at Brandeis University.
Okay, is this on? Yes. First of all, thank you guys so much for having me, and thank you to all of my fellow panelists for all their hard work in advancing this important harm reduction service. I'm a researcher at Brandeis, and I work on a number of harm reduction related projects, including those involving drug checking and low threshold housing, the latter of which is conducted in collaboration with Boston Medical Center. Some of my collaborators can be seen here, And this QR code, right now it links to the website about the housing project in general. It will eventually also link to these slides specifically. Today I'm specifically highlighting our efforts at piloting real-time on-site drug checking inside harm reduction housing sites. This project stemmed from a wider research study on these sites, low-threshold shelters which provide harm reduction supplies like sterile syringes, pipes, and cookers, and services such as wound care. One of them is pictured here, where residents lived in tiny houses and received services at a central trailer. These sites eliminated some of the restrictions present at more traditional shelters, like daily attendance requirements and sobriety prior to entry. Despite offering many significant harm reduction services, none of the sites we studied offered on-site real-time drug checking. While administering our harm reduction housing research study, we observed significant interest from residents and increased access to drug checking services. The recent emergence in the drug supply of xylazine, a veterinary sedative associated with high levels of sedation and slow-to-heal wounds, motivated residents' interest in accessing drug checking services. Many residents expressed a desire to avoid xylazine while purchasing dope, but dismissed the idea of traveling to a local syringe exchange solely for drug checking. As one resident said, yeah, the syringe service program, you can go and bring your stuff to them and have it tested, but they don't sit there in the community and be like, let me test this. I think there should be more of that because most people aren't going to be like, oh yeah, let's go to the syringe service program and have our stuff tested. Pictured here is one of our technicians, Abby Edelman, set up for drug checking in the central trailer at one of the sites. While drug checking has been implemented in a variety of settings, there is very little literature on drug checking provision at housing sites. The harm reduction housing sites we worked with offered a unique opportunity to pilot real-time on-site drug checking in a shelter environment. In response to considerable interest from residents, we developed a routine of monthly drug checking at 3 of the participating sites. Flexibility was key when working in a shelter environment. Our setup and flow differed based on site infrastructure, staff involvement, and research interests. We collected remnant drug samples, such as used cookers or residue from baggies, and tested them using test strips and an FTIR. At least 2 research staff members were present. One research staff member operated the FTIR. At least one other staff member gathered descriptive information, including the residents' use experience and what they suspected the drug sample contained, then ran the test strips. Almost all samples were tested with fentanyl test strips, but research staff also utilized xylazine test strips or benzodiazepine test strips, depending on the suspected class of drug. Participants typically received preliminary results within 15 minutes. They also received a card with a URL that would connect them with confirmatory laboratory results within the web-based platform StreetCheck, usually available within 6 weeks of the initial encounter. When possible and with resident permission, we also posted bag boards. Sheets which contained an anonymized summary of the composition of each of the substances tested that day. You can see an example template here. After receiving the results, some residents told researchers that they planned to switch suppliers or even dispose of their samples. One resident recounted an experience of finding fentanyl in his cocaine, noting his response was to throw it away immediately, flush. In addition to expressing an intention to make individual behavior changes, residents often expressed plans to use drug checking results to make community-level interventions. One woman said, when you guys tested before, everyone was like, holy shit. Nobody knew that all that dope had xylazine in it, and everyone was kind of like, oh my God, we got to readjust here. We have to figure out how to get dope without xylazine. Research staff established trust with residents through consistency and compassion. Once residents became familiar with research staff and the process involved, they began encouraging one another to utilize our drug checking services. Some contributed samples solely for the purpose of quote-unquote helping out with larger efforts to monitor the drug supply. Others took the opportunity to offer their own unique experiences, note specific contaminants that concerned them, or ask questions about the drug supply or drug checking in general. In conclusion, on-site real-time testing at low-threshold housing sites provides an important harm reduction service to individuals who might not otherwise access these services, but it is rarely made available in a shelter environment. Some residents began utilizing the service regularly, encouraging others to use it, and expressing a desire to use results to influence community norms. Communities across the globe should consider integrating drug checking services into housing sites and shelters. Future efforts in drug checking at low-threshold sites should examine their long-term impact on harm reduction behaviors among residents. Thank you so much to all of our drug checking participants for their enthusiasm and support of our services. This work would not be possible without them. And then this QR code is the same QR code that was at the beginning of the slide. And once again, right now it just links to our study website, but we'll eventually also link to a PDF of these slides. Thank you.
Hello. Thanks so much, Charlie. And I know for a lot of folks that live in the US, we know that a lot of overdose deaths that happen are within housing spaces because there's not someone that's there that can reverse the overdose. So this is a really cool way to, start to mitigate some of those overdose deaths and give people more information in places that don't usually have access to these kinds of services. And so next we have Zara. Zara Snapp is the director of Instituto RIA, leading research and advocacy in drug policy and harm reduction interventions in Mexico. She has degrees from Harvard and the University of Colorado thanks to full scholarships. Zara is the author of Dictionary of Drugs and advises Youth Rise and Acción Técnica Social.
Thank you, Yarelix. So I'm nervous to be around so many researchers with research methods that are so well established, but I'm really excited to be here. I'm really excited to be on this panel. So thanks for the invitation and to be here with so many of our colleagues from all around the region. So Checa Tu Sustancia is our drug checking program. It's as Yarelix said, we're an organization that does applied research and advocacy, and we're incorporating harm reduction interventions and also pleasure management. So in Spanish it sounds better, but gestión de placeres, understanding that most people use psychoactive substances because they feel some sort of state of well-being and they feel good. And we do all of this within a framework of social justice and peace building because in our region we believe that drug policy, we need it to be part of the conversation because it's full spectrum harm reduction, means drug policy and changing laws so that we no longer need to patch all of the harms of prohibition. So Checa Tu Sustancia is a community-led community health project where we are sustained by a team of volunteers that are multidisciplinary and who are well-trained and who allow us to carry this service forward. And we do it in two settings, community settings and nightlife settings. I'm going to speak a little bit about our work. And all of the people who are part of the team, including the team of RIA and the coordination, will identify as people who use drugs so that there can be also this interaction and trust built between. We do this within the context of Mexico, which means that we do this in a very insecure context where non-state actors play a big role, where promoters are really scared about having us in their events, where we have the ghost of fentanyl at our door. Fentanyl is a problem in the border region. I invite you to go to the sessions where we're talking about this. And I know there's a session right now that's talking about it with Verter en la zona in Mexicali. And the reality of the fact that now the prohibition of fentanyl and also vaping is in our constitution. We also are working, and this is kind of the parallel stream of normalizing risk and harm reduction and pleasure management services, which is it's a steep uphill battle, and also the politicization of people who use drugs. So every time somebody comes and uses the service, one, that's a person who we're having an interaction with and a conversation with, and two, that's a person who's willing to give us their data and information about their consumption, which then we are able to have more updated data than any government agency. So this is the campaign all around Mexico. The government is spending millions of dollars on having these types of campaigns, publicity campaigns, which it says fentanyl kills. They put it in other drugs to get you. But real friendships give you life. Stay away from drugs. Choose to be happy. So this is totally going to work, right? But so people are really scared. They don't even know what fentanyl is, you know? And fentanyl is obviously also medically available and used in hospitals, thank God, for people who are in need palliative care. But this is the campaign. This is the prevention campaign. And it's obviously also a response to our neighbors in the north and to the United States to say, we're doing something. Don't worry. We're really working on this issue. But this means that there's a fear in people who use drugs, people who don't use drugs, taxi, everybody, right? And it's like then boxing, family together, a united family gives you life. And that's why we don't have as much drug use in Mexico, because our families are united, not like in the United States where they're all fractured. So our model of care has to be also based on the fact that this is what the discourse is, and that's where then we talk about peer education, we talk about information based in evidence and science, but also based on the exchange of knowledge between people who use drugs, accompaniment, and agency and autonomy over ourselves. So we have 4 components, which most of the Latin American drug checking programs have, and across the region, which obviously Echele Cabeza are the ones who really opened the space for all of us to come after them. And this is the distribution of informational materials, a short questionnaire about the substance and the person who's using them, chemical analysis of the substances using reactive agents, reagents, colorimétricos, and fentanyl and benzo test strips, which are so generously donated from organizations in the United States. And then specialized counseling for the person and their friends, everyone. So it's also about all the people you're impacting just by having those conversations. And this is where I just wanted to show data from one intervention that we had in February of this year, which was a big festival. It's also about understanding that many of these people paid an entrance fee to get there, so they're paying more money for their drugs than we would see maybe in a community setting. And so what we saw here, and I can't really see that,
our eyes or so we do have the majority of people who analyzed drugs were male, 56%, but 40% were female and 2.25% were non-binary or other. You can see kind of the age range. There were 267 people who were interviewed. That means they had their drugs checked, and 1,395 people were impacted. They either heard a counseling session or they came by. So most people chose to use the service because they were curious. Others wanted to know the content of the substance. Others wanted to know if it was adulterated because of fentanyl, quality, and 11% because it was available. And that's really important because if we're not there, we can't do it. And 2 weeks ago, we had a venue cancel on us because the venue wanted to cancel, not the party. So the party wanted us to be there, but because if we're there, then we might be seen as a threat to other dynamics that are going on in the market. So the main substance that we test tends to be MDMA in this setting. 177 samples were expected to be MDMA, then 74 LSD, 42 cocaine, 13 TUSI. So TUSI is also taking over Mexico and Colombian invention. Ketamina, 2CB plus MDMA. And kind of in Mexico, what we're seeing is then we have, the substance that's present versus what it's present with presence of other substances or not present at all. So MDMA, only 141 of the 177 samples that we got were only MDMA. 69 of the LSD were only LSD. Cocaine, as we can see, 17 of the cocaine samples had methamphetamine. And this is something where then most people who are using cocaine in Mexico, you can just expect that you are going to have methamphetamine. And so then the big question is, because cocaine is perico and methamphetamine is crico, and so whether it's a pericrico or a crico-peri, which one is it heavier on? So you can kind of make some dosing decisions. But people just kind of know that it's going to have some of that in there. Then with the TUSI, we had MDMA and ketamine, which is what we would expect to see. MDMA and methamphetamine, ketamine and methamphetamine, cocaine and MDMA. So what we are seeing in central Mexico is not a fentanyl crisis. What we are seeing is and I wouldn't even call it a crisis, it's just the adulterating substance is methamphetamine. And then when we think about methamphetamine use in Mexico, it really depends on the populations that are using it and the mode of administration. So folks who are smoking it or slamming it or boofing it, it might be in context of men who have sex with men and chemsex and practices oriented around that. And then folks who are in party settings might also be doing some of those, but also probably eating it, no? Orally, because and that's what people sometimes say, but I like the pressed pills because it gives me the energy to keep going. And it's like, yeah, because your MDMA has meth in it. And so part of our messaging and talking to folks is that we're not being alarmist about it. It's just, how are you going to have the experience that you want to have? So then when we looked at which substances weren't present at all, in 21 of the MDMA expected samples, they had been completely substituted by methamphetamine. In 2 of the cocaine, they had been completely substituted by methamphetamine. In one of the MDMA was meth and an unknown substance. MDMA with, and Yarelix does amazing work on really defining market structures and whether there's really cross-contamination or not. And we know that actually most markets are pretty divided. But in this case, methamphetamine is cheap. It's very cheap compared to other substances. A gram of cocaine will cost you $50 US. A gram of methamphetamine might cost you $5, be less. So people might switch because of economic reasons. And then we had several unknown, because people find drugs and then they want to get them tested, which is great. So we've been using the tiras de fentanilo to be able to, we're actively looking for fentanyl, right? Actively. And we've done certain jornadas where we just, please bring us all the things you have in your drawers that you think might be funny, or if somebody's trying to sell you something, buy it and bring it, And we, in this intervention, had 2 that came out positive, for MDMA and for TUSI. But then, luckily, we have alliances that allow us to do confirmatory testing in laboratories, which we can't do in Mexico, because then it would be giving our data over to the military or law enforcement to be able to get that data, and we're unwilling to do that. And so then we found in that MDMA sample was actually an amphetamine analog, BZP DIHCI, which Yarelix was like, I've never seen before, but it has euphoric and stimulant effects. And this was somebody who had come from out of the country, who'd come to Mexico, who'd bought drugs, we weren't quite sure, from a friend, he said. And we did, and it was negative for fentanyl, but when we did 6 fentanyl test strips, they came out positive from different brands, because we're very careful about false positives, because we've had some very negative experiences in Mexico where research has been published using false positives, and which then damages so much of the work that we're doing and creates a hysteria. Then with the other one that was positive in the TUSI sample, that did come out positive for fentanyl. So it's tough. We don't have a machine, So I'm like packaging drugs and trying to, send it through the mail and hope that they don't come back and find us, and hope that everything will be good on the other side too, right? And then we're also doing benzodiazepine test strips. And as you can see there, in TUSI, 2 came out positive, and in MDMA, 1 came out positive. Some of the frequency of use about the substances used: once a year, every 6 months. Yeah, you can just kind of see some of this. And we publish all of our results every 2 months on our website, checkattusustancia.org. Whether they had consumed previously or not, 78% had not consumed previously. Whether they had analyzed their substances before, 67% had never analyzed. 21% had with Check Out Tu Sustancia, and 11% had with other services. So just as conclusions, the ghost of fentanyl, it reduces the sense of risk of other substances, because then when we tell them it doesn't have fentanyl, oh, okay, it's fine. So then I'm just going to I'm going to mix, I'm going to do whatever my habits might be. So we have to be having conversations about that. And it's a problem with the narrative that's coming from the government. We're not alarmists about methamphetamine. And so folks don't tend to have fear around the substance. But we also do have to be conscious that there are a lot of different groups that might be methamphetamine is causing problems in certain communities, among young people, in more rural communities, where it's just being kind of left in the path, and people are, and we have a guide on meth and fentanyl use that kind of helps with that. The form of administration is very dependent, and it's fundamental to have confirmatory testing to really be able to understand market dynamics. So for us, risk and harm reduction and pleasure management is one of the crucial forms of politicizing people who use drugs in order to propose different public policies. And so these are some of our volunteers and our groups and our interventions. And so, muchas gracias. Thank you.
Thanks so much, Sara. Yeah, and that's a huge part of drug checking. There's a lot of like alarmist narratives around fentanyl. Obviously in the US, in our opiate supply in particular, it makes up a huge part of our supply. However, in non-opioids, it's not so clear. A lot of us as drug checking technicians in the US have seen that there isn't a ton of adulteration of fentanyl in the non-opioid supply. Although there is some that happens, and because of that, we should keep using naloxone, we should keep drug checking, doing all these things. And now these narratives are harming communities in Latin America, so we have to keep combating these false narratives. Okay, next we're gonna have Tristan Vassaux. Tristan Vassaux is the general coordinator of, is it AGR? AGR, a harm reduction association in French Guiana, and regional coordinator of the SINTES system, a drug checking program led by the OFDT, French Observatory of Drugs and Addictive Trends. Additionally, Tristan is a PhD student in anthropology at the Université de Guyane, okay, thank you. Exploring electronic music in French Guiana. Thank you.
Thank you. So here we go again with the best accent for a presentation in English. Plus I caught a cold, so I hope you will understand me. I will talk to you about I don't have the... So I will talk to you about the new trends in psychoactive substance use in French Guiana, and how a territorial and community-based harm reduction approach supported by the SINTES monitoring system help us better understand local dynamics. Before delving into the topic, I would like to introduce my territory. French Guiana is another CIS territory of France located in South America, characterized by exceptional cultural and ethnic diversity. Its population is composed of Creoles, Maroons, descendants of enslaved people who fled plantation to seek refuge in the forest, various indigenous groups, and a significant Hmong communities that migrated from Laos in the 70s. To this local mosaic, continuous migratory waves add further complexity. French nationals from mainland France, known as metropolitans, regularly settle in French Guiana. The territory's proximity to the Caribbean and South America also brings substantial migration flows from Haitians, Surinamese, Guyanese from Guyana, Brazilians, as well as Peruvians and Venezuelans. However, this cultural diversity exists within a post-colonial context marked by persistent social tensions. Regarding psychoactive substances, public authorities' attention is focused almost exclusively on 3 substances: alcohol, cannabis, and cocaine, including crack cocaine. This narrow focus is partly due to a methodological bias. The few available data come mostly from studies conducted within addiction care services. Thus, they primarily reflect the reality of people seeking treatment, reinforcing the idea of a dominant triad without taking into account the diversity of consumption context, leading to a confirmation bias repeated in each new study. This bias shapes risk perceptions across the territory and obscures many emerging dynamics, particularly those linked to the new substances or festive and community-based use. To address this lack of data, the SINTES scheme, the National Identification System for Toxics and Substances, operated by the French Monitoring Observatory for Drugs and Addictive Trends, offers a complementary approach. As a regional coordinator of the SINTES program in French Guiana, I oversee the collection and sending of samples of substances circulating through the territory, aiming to better document the substances and uses actually present. We collect substances and send them to laboratories in mainland France, and results are received approximately 3 weeks later. The system enables the establishment of a health surveillance network across French Guiana. And if you would like more information, you can scan this QR code. Thanks to this work, we are now able to offer an updated view of drug consumption trends in French Guiana beyond the classical figures often cited. Let's begin with cannabis, one of the most widespread substances in French Guiana. In its herbal form, cannabis is primarily cultivated locally. The plant adapts very well to the Amazonian environment, and there is a significant development of artisanal cultivation. Since our association operates frequently in festive settings, we have access to local producers. They often seek to offer products with varying THC and CBD levels to meet consumers' preferences. The distribution network is mainly based around small producers who supply relatives and close community circles. Regarding cannabis resin, we collected a sample from a user who indicated that it came from Morocco. According to several of our contacts, resin bricks are sometimes exchanged for cocaine bricks due to the lower market prices in French Guiana compared to the mainland France. The analysis of the sample revealed a THC concentration of 38%, a particularly high level, significantly above the national average recorded in the SINTES network samples. Now moving on to cocaine, whose trafficking routes are now well documented. Due to its geographical position in South America, French Guiana has become a key hub for cocaine exposed to Europe. Neighboring Suriname previously played a significant role in this process, particularly due to historical ties with Amsterdam. However, reinforced border controls in the Netherlands have gradually shifted trafficking routes towards French Guiana. Cocaine is a substance we collect only occasionally. When collected, analyses show very high purity levels between 80 and 90%, with no adulteration. The price on the local market is around €20 per gram. Cocaine circulates throughout the territory, reaching even the most remote indigenous areas, such as Camopi, as you can see in green, where supplies mainly comes from neighboring Brazil. This widespread availability has led to transformation in consumption patterns. Crack use has sharply increased in French Guiana since the 80s. Prices are extremely low, sometimes as low as €1 per hit, making it highly accessible and exacerbating addiction dynamics. Crack collection are primarily conducted by our health and addiction care partners, and only when there is suspicion of product adulteration, which in practice has never happened. In addition, we observe the circulation of two substances mainly imported from mainland France, ketamine and LSD. Ketamine is brought to the territory in liquid form and then crystallized locally for resale, especially during techno parties. Laboratory analysis confirms that the circulating product is pure, without adulterants. When we conducted field investigation among local dealers, the majority reported being unfamiliar with ketamine, describing it as an external product. Regarding LSD, it either arrives directly in travelers' luggage in liquid form or is ordered through dark web platforms and delivered to French Guiana. Currently, LSD consumption remains largely confined to alternative techno scenes, without significant spread to broader social context. Both ketamine and LSD are predominantly consumed by the so-called metropolitan community, white Europeans who have settled in French Guiana. Now I would like to address substances for which documentation remains very limited. Concerning opioids, we have identified a few heroin-injecting users, primarily in the city of Cayenne. It concerns brown heroin, a less pure form than white. At this stage, French Guiana does not appear to be linked to North America production flows, and fortunately, no fentanyl circulation has been detected. However, another practice deserves attention. In neighboring Suriname, a codeine-based cough syrup called Tusadril is sold freely in stores. In Western French Guiana, especially among young people, the maroon ones. The syrup is diverted from its medical use and consumed mixed with soda, mainly Sprite, a practice inspired by the lean phenomenon popularized by North American rap and trap music scenes. Another interesting substance is MDMA. Present in French Guiana for about 10 years, its use is now well recognized, primarily in festive environments. However, in French Guiana, MDMA quickly acquired a local nickname, especially in the western part of the territory. It is called sucru, meaning sugar ecstasy. The name comes from the resemblance between MDMA crystals and local cane sugar crystal. For several years, this nickname created confusion. Some actors mistakenly believed it was a new synthetic substance when it was simply MDMA in crystal form. More recently, we have observed an evolution. MDMA has been transformed into a liquid form, making it easier to consume and more attractive to younger audiences, especially the maroon ones. This new version is marketed under the evocative name Pikachu, using bright colors and childlike branding. Again, there was a delay in testing this product. Several health and prevention centers in Western French Guiana raised alarms, suspecting a catinone or a new synthetic substance. A recent sample analysis confirmed it was indeed MDMA, but with extremely high dosage, around 600 and 800 milligrams per dose, far above usual standards, leading to several hospitalizations, especially among young users. At the moment, we are on alert on this project, and that's a perfect example on how SINTES can help us. This case highlights a significant cultural trend in French Guiana, a strong preference for making psychoactive substances smokable or drinkable. In other words, when a new substance seems to emerge, it often reflects a cultural transformation of an existing product, redesigned to be more attractive and better integrated into local consumption practices. In conclusion, the case of French Guiana clearly demonstrates the importance of adopting a territorial and community-based approach to understanding consumption dynamics. Beyond classical substance, local circulations, cultural transformations, and practice imported from North America, Europe, or neighboring South American countries shape specific, often invisible consumption patterns that are not captured by national studies. Thanks to the SINTES system, we have been able to document some of these emerging realities, identify new risks, and adapt our harm reduction strategies to the specificities of the territory. Thank you very much for your attention.
Thank you so much, Tristan, for your presentation. It also highlights the importance of when there's drug narratives that are based out of myths or inaccuracies, the power of having drug checking to be able to clarify what's really going on, and also highlighting how different regions impact the local drug supply. All right, and last but not least, we have Dr. Timothy Piatkowski, is the director of the board for Queensland Injectors, Voice for Advocacy and Action, and a researcher and lecturer at Griffith University. His research philosophy is rooted in harm reduction, emphasizing the importance of promoting informed decision-making amongst people who use image and performance-enhancing drugs.
Hi, everyone. Good afternoon. Thanks for having me. Really, really pleased and such a privilege to be able to speak after all my wonderful colleagues here and close off the session. Hello? Okay, even better. Okay, after a false start. So, presenting today the findings from the Australian Anabolic-Androgenic steroid checking trial. Now, this was actually the world first steroid checking trial. It was done in 2024, and now happy to announce that it's a fully funded program in 2025, expanding not only in Queensland, but also in Victoria as a trial as well. Now, at this point, we provide individual results to people along with a health conversation to help them make better decisions about the steroids that they use. I'm here to present on a fantastic team, one of whom is here today, and it's a real privilege to be able to present the work. Obviously, we're here in Bogotá. I love the culture, I love the food, especially love the papaya, but want to acknowledge that the work was done in Australia, and want to acknowledge the traditional custodians of that land, who are the Aboriginal Torres Strait Islander people. Acknowledge the elders past, present, and emerging. Extend my respect to all Aboriginal Torres Strait Islander people. Want to acknowledge the bravery of the peers that came before us, before me. I'm a person with living experience of steroid consumption, and stand on a 35+ year legacy of Quiver. So to orient us all to the same understanding, when we talk about steroids, we're talking about a class of image and performance enhancing drugs. There are over 32 different steroids documented in the literature, and hundreds, if not thousands, of designer steroids. These are steroids injected intramuscularly, as you can see the testosterone up the top there. These are oral tablets taken like oxandrolone or stanozolol. Then you have designer steroids like Superdrol. You have other image and performance enhancing drugs like insulin or human growth hormone injected subcutaneously. And I guess this is just to demonstrate the breadth of this class of drugs. Now, these are used by quite a large proportion of the population. We know that 3.3% of people are using these drugs. 6.4% of men, 4% of women. They're used by a diverse group of people, people seeking well-being, youthfulness, aesthetics, strength, and so on. It is your next door neighbor. It is no longer Arnold Schwarzenegger. Now, I'd be remiss without telling you that these drugs do have harms associated with them. There are substantial physical harms, hypertension leading to cardiomyopathy. There are psychosocial harms like depression, mood disorders, and so on. However, many of these harms are manageable using harm reduction techniques and under medical supervision. What is not manageable at the moment is that we have a toxic and unregulated steroid market, and it is booming across the world. And the result is flesh-eating bacteria, people having part of their glute cut out. In Australia, much like, we're actually leading the rest of the world in terms of the increases here. We've had, in the past decade, a 218% in our steroid arrests increase. We have, at the same time, seen a 1,400% increase in our steroid seizures at the border. So going from 30 kilograms in 2010 to almost half a ton in 2021. Globally, that's at about 750% of an increase. I didn't put it on the slides, but I thought it might be worth mentioning. Now, we have wonderful harm reduction innovations in this space. We know that drug checking is acceptable and feasible. We also know that it's acceptable and feasible among people who use steroids, because we did some preliminary work in 2023, if you see the QR code there. In 2024, the Queensland government opened or allowed us to open Checkpoint. Checkpoint was run through the Queensland Injectors Health Network, and we have a representative from Quinn here. And Checkpoint was the first drug checking, or was our Queensland drug checking service, came after the drug checking service in Canberra. Now, at Checkpoint, we decided this was the time. This was when we were going to do steroid checking. Now, why hasn't this been done before? Well, apart from Australia and some of my colleagues in Switzerland, steroid checking there are a few challenges to overcome. And you can see one of our papers on this below at the QR code. It's a constellation of factors that have to come together. You need the right team. You need a lab, an off-site lab. You need trained chemists. You need a driving force. You need community to be involved. And this all has to come together somehow. Nevertheless, we did it. In 2024, we ended up on national and international news. You can see one of the videos coming from that there. And some of the members of community, my community, that were involved in the trial. This was actually a community-led trial as well. I should mention that I and the steroid-using community drove this from the very beginning. We came together, we submitted the samples, we did the research, there was no co. It was all peer-led. It was us. In terms of the way we house this in a research project, this was done as a mixed methods explanatory sequential study. It was done in 3 waves. And each of these waves had 2 phases. So between April and June, wave 1, wave 2, June, August, and then wave 3, August to October. Now, in each of the phases, so first phase was data collection. I did some flashy social media to get people to submit the samples. The samples came in, as you can see. That's what steroid vials look like. And then we shipped them off to the university lab and we had them analysed. We used a few different techniques. We tried a radian ASAP, then used some LCMS and settled on LCMS actually. And then we disseminated those results in a report to community. In phase 2, we interviewed community members, people who use steroids, and we asked them, we presented the results and we said, what do you think? How does this impact your practices? We had a bit of a semi-structured interview guide, and then I analysed it using a health belief model and subjected it to thematic analysis. So this is what I was meant to talk about today, just wave 1, but there'll be some bonuses. Now, in wave 1, we actually only got 32, well, not only, we got 32 samples in and we could test 23. You can find the report here in this small QR code. Now, of those 23, about 13% of them were unexpected, so different steroid than what was going to be in there. Oxandrolone had some stanozolol in it and some testosterone in it. See the report. You can also see here the bigger QR code. We've actually published this in Addiction earlier this year, and you can find that there. In terms of the interviews, and this is the real interesting part I want to draw your attention to, interviewed 25 people, 20 men, 20 women, about 35. There were some key themes there around how important it was to have accurate testing, how important it was to have representation, around the limitations of the subjective health markers that they were using to practice harm reduction through, folk pharmacology, as we call it. But I just want to draw your attention to this one quote, which I really love. Yeah, these results, I would be quite confident in my ability to change my usage for sure. I would know that if things were for the most part incorrect, I wouldn't use them or I'd reduce my use heavily. So yeah, that's the harm reduction side right there. And that was very, very much representative of a lot of the other participants as well, I should mention. We also produced community drug notices. We basically made a steroid alert system. You can find the paper published on this here at this QR code, and this is a bit of a rundown on what we did. It's outside of the scope of today, but I just thought I'd give you at least a reference to it. Again, some flashy social media here, which I really like, and fantastic response from community. We've published a number of these afterwards as well. When I submitted this abstract, actually, this work continued, and I thought it would be a bit silly not to present some of the other stuff, the cool stuff that's been happening since. We actually, we've done wave 2 and 3. You can find wave 2 report and wave 3 report here. We followed up with some interviews. We followed up with a survey after wave 3. But most interestingly, I just wanted to give you a picture of the market from the whole wave 3 report, from all of the trial, published in February this year. 105 samples in and tested. Of those, over a quarter, different steroid than expected, not the right one, potential harms there. 50% underdosed, less steroid than expected. Only 6% overdosed. And so really starting to see some differences there around what people expected and what's happening. And the follow-up interviews, that wave 2 paper currently under review, survey waiting to be analysed. What are the future directions? Well, currently, as I indicated, this program is continuing in Queensland. We have almost 150 samples that we've taken in and are being tested right now. We have a system of continuous data collection being run in consultation with my community. We also have an amazing Steroid Connect program. We have a steroid peer educator, someone with living experience, working on a phone line, working that anybody can call, free to call, working on an online forum and having an online presence through High Ground, and who does in-person harm reduction at needle syringe programs and providers at Quinn, and also at the site of steroid checking. And so together, this is something really special, I think. Now, what I want to draw your attention to, most of all, is that steroid checking is fantastic, and I'm really happy to present all of this, and Steroid Connect is great. But I think what this speaks to more than anything is this is a tool. I think this community, my community, has been underrepresented for over 40 years. We don't have any initiatives. We aren't seen in harm reduction initiatives. I believe this is the only presentation on steroids at this conference. And so I think if there's one key takeaway from today, I love drug checking, and I love that we can give people information and help them make good health decisions and facilitate their autonomy. But if you have a drug checking service, you need to equitably represent people, and people who use steroids are part of that part of communities of people who use drugs. And so I challenge you, or I encourage you, please, I think you really, really do need to try and incorporate this, and we internationally should try and incorporate this. And so would love to collaborate, or would love to discuss that further. And if there's one takeaway, it's that it's not only equitable representation in drug checking programs, but also equitable representation in harm reduction for people who use steroids all over the world. Thank you so much.
Thanks so much, Tim. That's really important and interesting. And also, we have so much that we could do with drug checking. So pushing the limitations of what it means of who we serve and what technologies we use is really important. All right, we have like 12 minutes for some Q&As. So does anyone have any questions for our panelists today? We can go to the party. No questions? Okay, well, people, like, raise your hand if you have a question. In the meantime, I'm going to do a shameless plug for, there's an organization called, well, we're like a group of people all over the world called the Alliance for Collaborative Drug Checking. We're having an online virtual summit next month, and we platform a lot of people from across the world doing drug checking. So if you want to join, we have flyers up on the front. There's a registration fee, but if you can't pay for it, we give a free code. So just going to say that. Questions?
Yeah, we have one right here. Hello. I have a technical question for our last presenter, actually. I'm so sorry. It's day 2 of the conference, and I'm no longer remembering names. My name's Zelda. I work with the People's Harm Reduction Alliance in Seattle, Washington. I have a technical question, actually, for you about the methods that you use to check the steroids. You mentioned trying a couple different mass spectroscopy, FTIR, and settling on LCMS, liquid chromatography, mass spectroscopy, to check them and see sort of what the strength of the steroids are. I was wondering if you could speak more to the different methods and how you were able to set up using LCMS, because that's a technology that's not super accessible to a lot of community-based orgs. It's something that universities have, community-based orgs don't, but would be really useful for folks in the US who are making their own hormones in an environment where folks are making hormones that are often substances that are difficult to check on the technology we have access to in current harm reduction drug checking programs.
So I think I rushed through this bit as well a little bit. So we had a Radian ASAP, which is I guess used for presence detection, and that was gifted, or is that the right word? We had it for a bit, and now we don't have it. We borrowed, and we used that initially because I guess that's what the chemistry team wanted to play with. I was at the mercy of the university's chemistry team, and they did that. They built the library on that, and then they built the library on the FTIR as well. So we had that as well, and we had those for presence. I wasn't stoked with just presence, and I should have mentioned in wave 1, we had 23 presence results, but only 1 purity result. The purity was done through LCMS. Now that's because we have an Orbitrap 360 in the lab, and that's the machine that they use. And I guess coming back to what I think your point is, and I really love it, is we have people coming through the program now who, similarly, we have had some
we have a political environment in Queensland as well, and people are manufacturing hormones as well, and steroid checking is for everyone, and so those people access the program. I think part of that system is having a partnership with universities and community organisations like we do, and making sure that there's some investment there in terms of, like we can do presence on site, and that's great, but also can we do purity and can we partner and do those types of things? And I think this gets the ball rolling for other universities and institutions to start to partner with community orgs and do equipment share and those kinds of things, because I guess we co-funded a lot of it in terms of seed funding initially until I got more funding down the line. Yeah, but happy to chat more about methods after.
I've seen 2 hands already, so I'm gonna.
Hi there, my name is Gotham. I'm an undergraduate student at WashU in St. Louis in the United States, and I work at the county jail there. So I'm really interested, just from your own countries, from your own experiences, maybe within the literature, what kind of drug checking measures have been successful within jail or justice-involved settings, whether that's in your countries or whether you've read about that in the United States?
I mean, it doesn't exist in my country. And I think in most of, at least the Latin American region, which is where I work, and drug checking doesn't exist in any sort of prison setting. I mean, we're lucky if we could get some sort of, like, any sort of substitution therapies or, but yeah. I mean, just to give a context, like in Mexico, naloxone is scheduled as a highly prescriptive drug, so you can't even get it unless you have a prescription.
In France, we have difficulties to have access to sterile equipment in prison, so drug checking, it's far, far from us.
I just know about this because I work at the New York City Department of Health, and we have like money, and so a lot of companies like target us. Are like, hey, we got a thing, want to sell it to you. The only reason why I know about some testing is because obviously like these companies want money, so they'll go to large institutions to try to sell their machines. And there's this one machine that's a portable GCMS, and one of their selling points was that they go to prisons to market these machines because there's like right now one of the things that's happening is that they mail K2 on paper, and then so they take the papers and they like rip them apart and they smoke them in prison. So they were like showing off like, yeah, we can use this machine to like test K2 in prisons. And I was like, ew. But yeah, so like I think there is drug checking happening, but it's not for the purposes of helping people. It's often like to criminalize people or to try to figure out ways to stop the drugs from going into prisons. But I think it'd be great if there was a way to do that, but there's such a difficult place to engage politically, and yeah.
Well, I just wanted to say my congratulations. Can you hear me? Yeah. My congratulations to all of you, because you're doing a work that the state institutions in the world are not doing, though they should. So congratulations and thanks for that. And my question is an open one for anyone who wants to answer it. And is, in your opinion, how can these drug checking programs can be used as a tool to support more comprehensive drug policies in your countries? Thank you.
Oh, wait, really? I started last time. Come on. I mean, Aldo from Mexico. I mean, so that's basically what we're trying to do, is we're trying to build, on one hand, and I think there's lots of objectives to drug checking and community-led drug checking. On one hand, we're building a database that allows us to have information about people who are using drugs and our frequency of use and our education level and our self-care and our networks and how it's working and how much we're paying and how often and etc. And that's important because at least in our country, we haven't had a national survey on drug use since 2015. So we don't really know what's going on. And from 2015 to now, so much has changed. People's attitudes, and our access to substances. I mean, people use ketamine now, and 10 years ago, we didn't have really access to ketamine. Tusi is a whole new, the invention. It comes out in 2012-ish in Colombia, and now we see it a lot. So there was a time when we went through a phase where LSD was being replaced by N-bomb, and we don't see that anymore. So it's about building what does the market actually look like, because all of our policies over the last 10, 15 years have been completely based on suppositions of what is happening and assumptions and ideas, but not in reality. So it's about building that. And parallel to that, it's about creating a cultural shift so that politicians see that there are people who want policy change and politicizing our use, and recognizing that it's possible to have drug use that that can live cohesively with our day-to-day lives. And that has to do with just, so we're using that to then be able to push for policies once we see that there's a political opening, and have communities and a movement that wants to push for those changes. And a lot of us live in that the cannabis community politicizes, but often other people who use drugs don't necessarily. And this also stems from then our main objective in RIA around, because then the big focus is on prevention. Let's just prevent drug use, and we saw it's gonna work. Is around how do we delay age of initiation? So how does that age increase? People wait to use legal and illegal drugs, alcohol, tobacco, cannabis, whatever. And that because we can understand that pleasure, you might have more pleasure when you're older if you wait, It depends on the person. I bet many of us here started when we were teenagers as well. And the other piece is around how do we prevent problematic drug use or chaotic or whatever term we want to put to that. Drug use that isn't fulfilling the needs of the person, and also understanding that much of that use is related to other situations around the person that have nothing to do with the substance. And so, but that has to do with or if we know about methamphetamine, if we know about opioids, if we know about substances, if we do better drug education, then maybe, and better decision making. And if you have somebody you can talk to, and they come back and talk to you and say, I used that, and I changed my dosing, and this was my experience tonight, and it was great. I've had a great night. Thank you. You're like, excellent. And next time they'll come back. So it's also about how we're building this knowledge exchange and trust between folks so that we can live at peace with psychoactive substances.
I think we have a territory, a special territory in French Guiana, because we are under the law of France, of mainland France, but everything that happens in French Guiana is not the same in France, and maybe we have like 20 years of late with our mainland France. We can feel that there is a repressive ways that becoming more insistent in France. But in French Guiana, we are good relations with our health agency, and they followed us because harm reduction in French Guiana is not well perceived, understood, or seen. And we are at the association, my association, we are the only association that represents harm reduction. So as I can see, and I will take the Pikachu product, the Pikachu substance, when we make the alert, our health agency followed us in 2 weeks, and they made a group meeting with healthcare in French Guiana to send the message. And we try now to make some information translated in local language to pass the message. And so I think the work of my association is well perceived, and we can work together with our agencies in French Guiana for now. And I hope it will last.
I'll try and be brief because I could talk about this for a very long time, but obviously one of the benefits of drug checking is it allows us to know what's circulating in the drug supply, and that's probably one of the reasons why it is popular with funding agencies and government agencies. I can give you examples in British Columbia of how drug checking data has been used to inform clinical care in hospital settings, treating benzodiazepine withdrawals after opioid overdoses. It's also been used to create dosing decisions for people who are going to be accessing novel safer supply programs in Vancouver. And then in sort of more progressive drug policy, the Drug User Liberation Front used drug checking data to support their application to the federal government in their attempt to get an exemption for their Compassion Club. And it, on top of just the coronial data that we can list over and over of how many people are dying, it's actually better to show what is circulating out there, because not everyone who's accessing the unregulated drug supply that is so toxic is dying. So that's a different source of information that we have access to.
I think mine is a little bit more nuanced. So in Australia, to give you the picture, steroids are highly criminalised in the state that I'm from. They are a Schedule 1 drug, so similar penalties for steroids, heroin and methamphetamine. It's 25 years in jail for possession, or up to. I've never heard anyone get that sentence, but it's the threat, right? I think my overarching research program, and this is one of the funded programs that sits in it, one of the streams has an intention around drug policy and steroid policy in particular. And I guess they do feed into each other in that I would like to see testosterone, for example, decriminalised, at least testosterone decriminalised. In the United Kingdom, for example, it is. I think we've seen a large amount of pathologization and neglect from medical models around people who use steroids. Programs like this, steroid checking, give, I guess, an insight and an interest around funding and around from policymakers as well, and start to allow us to have these discussions around decriminalisation, learning from other international partners and organisations around what they do. So I think, yes, like it's on the horizon, it's on the agenda, starting to see traction, maybe in 5 years, maybe in 10 years. I can hope.
All right. Well, thank you so much to all of our panelists for all of your work and information that you shared with everyone. Thank you all to the people who came. And yeah, hope to see you around in the rest of the conference.